Okay, welcome to Podcast Pediatricians episode number 30.
Woohoo!
They said it couldn't or shouldn't be done. Could never happen.
And they were right.
Yeah, we'll see.
But here we are.
Let's get through it.
Ready for some orthopedic stuff?
You bet.
Okay, now many of my buddies in medical school went into orthopedics, and it's truly a very difficult specialty to get into. So usually it's the smartest people in your class went into orthopedics. Agree? No? Well,
Some
my
of them.
experience, but
Yeah.
they do have a reputation for being somewhat less cerebral, a specialty, than others in medicine. Kind of like Todd from Scrubs.
Oh, yeah.
You
Good
watch
show.
The Todd?
Yes, absolutely.
So, before I tell this tired medical joke, I want to be clear that the average orthopedic surgeon is way smarter than me and way smarter than Matt.
Way. That was a given, dude.
And we do want to thank Doctors M and Dr. S, pediatric orthopedic surgeons at the two local children's hospitals near us, for answering some of our questions about pediatric scoliosis. And as usual, any mistakes we make are on us, not on them.
You bet.
Ready for the joke?
I'm ready.
Okay, so a priest and a rabbi and an orthopedic surgeon walk into a bar. And no, all right, wrong joke. Okay, a pediatrician, a pediatric neurosurgeon, and a pediatric orthopedic surgeon are all running for the elevator. First, the pediatrician lurches for the closing elevator door and throws his hands into the open doors as the two surgeons look on aghast. And the pediatrician says, well, he can always get by without his hands, but it's his precious brain that he must protect. And then the neurosurgeon lunges and sticks his foot in the closing door and says, gotta protect my hands. They are a gift from God. And Matt, you know where this is going.
I know where this is
And the
going.
orthopedic surgeon lunges gracefully, since he's the best athlete in the group because he's an orthopedic surgeon, and sticks his head in the closing elevator door. Ba-dum-bum-bum. Okay, Matt, our disclaimer.
All right. Disclaimer. We always like to let people know that we're sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community's standards of care. Okay, so this is the scoliosis episode, so let's get to it. We're going to mostly concentrate on the most common type, which is adolescent idiopathic scoliosis. So first, let's get some definitions down. Scoliosis is a curve of the spine in the coronal or the frontal plane. This means that when you're looking at the spine from the front, it curves either to the left or to the right. By definition, it's abnormal if there's a 10 or more curve as measured by something called the Cobb angle on X-ray. The Cobb angle is an intersection angle of the lines drawn at the top and the bottom of the maximum curve.
Now, when I was a radiology resident, Matt, we used to do these measurements, but any self-respecting orthopedic surgeon always ignores radiology measurements and does it for him or herself. And for good reasons, because they're just much better at it.
Yeah. And they'll usually look at it, if you remember, and like dismissively say, like, yeah, I know what the radiologist said, but I'm doing it myself.
Right.
So the direction of the curve is defined by the convex or the rounded side or the hump side. So if there's a curve so that the hump is on the right and the top of the head and shoulders go to the left, it's a right curve. An idiopathic curve means that there is no definite cause for the curve. I think we've used the term idiopathic in past episodes.
We have.
Essentially, it just means like we don't know why. So these types of curves have no contributing issues that would be like muscle disease or a syndrome or a congenital bony abnormality of the spine. So it doesn't have any of these at all. It's we don't know why. Congenital means when the patient was born with the condition.
And I think we said this before, but I've heard idiopathic defined as when your doctor is an idiot and the doctor and or the patient is pathetic, which is a bit harsh.
It's a bit harsh, but it certainly goes to the we don't know why type of thing, right?
Right. Now, a typical curve in severe adolescent idiopathic scoliosis, that's AIS, is a right thoracic plus a left lumbar double curve. That's when it's severe. The location of the curve is defined by the most deviated vertebra or bone of the spine in that curve.
Okay, so some basic anatomy. The spine itself is divided into block-like vertebral body segments in the front, so kind of toward the belly button side, separated by the spongy, cushiony discs that can protrude with age. So that's in the front. And then there's a ring of bone behind each block that surrounds the spinal cord. So this is kind of toward your back's side. The ring is called the vertebral arch, and this ring permits nerves to come out of the sides of the spinal cord. So if we imagine that the block is in the front, and then this horizontal ring is fused to it in the back, that's the way the spine gets set up. The top 7 vertebrae in the neck are called the cervical spine. The next 12 upper back vertebrae make up the thoracic spine. Below these, in the lower back, are 5 lumbar vertebrae, and then there are a few sacral vertebrae, and then the coccyx bone or the tailbone. Have you ever bruised your tailbone, Rob?
Actually, I have not. But when I've seen some patients have it, it can last. The pain can last for weeks
it's
to months.
Excruciating. You have no idea how often you use that area of your body until you actually, bruise or fracture that area.
I don't know, Matt. I don't use that area of my body that much, but I figure out in like southern Jersey, that's
really?
probably
well, every time I see you, you're
area.
sitting on your arse, so I don't know.
Okay, Matt. Here's your question: what do the following people all have in common? Barack Obama, Beyonce, Muhammad Ali, Madame Curie, Dua Lipa, Melania Trump, Gandhi, and Dolly Madison.
No idea, but it probably goes to the theme of this episode.
Which is what?
Scoliosis.
And the answer is no. They have nothing in common.
Okay.
I made that up. But do you know who Dua Lipa is?
I have no idea.
Oh, she's a singer. She sings New Rules. If you're under him, you're not getting over him. Words to live by.
Oh, very, yeah. Okay.
Very
in one way or another.
All right.
Yeah.
All right, here's the real question. What do Laura Dern, James Blake, Daryl Hannah, Sarah Michelle Gellar, Buffy, Usain Bolt.
Her name?
I think so.
Okay.
Usain Bolt, the Olympic champion, Elizabeth Taylor, and Liza Minnelli all have in common.
Okay, so I can't get this part wrong.
No, you
right?
can't.
All right. I'll bet they all have scoliosis.
They all had or have scoliosis. Ding, ding, ding. Correct.
Nice.
After the break, we'll go into a deep dive of the twisty roads of scoliosis. We'll be right back. Okay, we're back, Matt, and continuing our tradition, let's have some snacks. And we've both done a bit of traveling in the past few weeks. I don't think you have any snacks from Italy.
No, I don't.
How was the food?
Awesome.
What was your favorite?
The tomatoes, actually. I broke it down to something really basic.
I didn't think that's what you'd come
I
out
ate
with.
a ton of different food. It was all really good. From an affordability standpoint, I wasn't eating in the 5-star restaurants at all. I had my whole family with me.
The 1-star restaurants in Italy
They were
are
great.
better than
yeah.
the 4-star
They were
here.
really good. Hey, listen, I got takeout once while I was in Italy. It was like in a Chinese takeout box type of thing that we're all used to from the Chinese restaurants, but it was pasta. And they put any sauce that you wanted on it, any of the noodles that you wanted, and any meat that you wanted. It was
And
great.
it's
It was like
fre-
$7.
It's like
fresh.
fresh
They made it
pasta?
right there, like
Right.
10 minutes ago.
You weren't one of those Americans
awesome.
who were going to McDonald's in Italy.
No. In fact, at one point, somebody in our group, whose name will remain unmentioned, recommended going to the Hard Rock Cafe. I'm like, I am not going to the Hard Rock
Thank
Cafe.
you. I mean,
please. I'm here in Italy for an exotic experience. I know what the Hard Rock is.
just put a sign in your back, idiot American who's overseas going to the Hard Rock Cafe. And how about the gelato?
The gelato was excellent, this way and that. Every single gelato I had was good par excellence.
Did you use the rule that you look at the pistachio and if it's muddy colored, it's quality? If it's bright
I did
green,
not, but
walk away.
Interestingly enough, I had the pistachio, and
Did
that's
you?
why I chose. And I
Was
didn't
it
even
bright
know that
green or
rule.
kind of muddy?
It was a little muddy.
That's what you want.
And it was superb.
Yes, and you get it with pan.
Oh, my
I think
gosh.
that means cream. My favorite
I did
place
not.
is near the Pantheon in Rome.
Okay.
Giolitti or something like that, but just great. All right, so I was in Quebec and Montreal for a week when it was brutally hot here, and it was also brutally hot there.
Oh,
I thought
really?
I'd get away. But I brought some treats for you. One is maple cream cookies from Quebec. So here you go.
All right. Now, do they use real maple syrup, or do they use
Real maple
that
syrup.
gunk
When you
that-
buy it, it looks like you're buying a can of oil if you
Okay.
buy real maple syrup.
All right. Let me give this a shot. Very mapley.
I know.
I'm not usually a fan of maple, but this is pretty tasty, actually. Plus, the fact that it's shaped like a maple leaf gives it that extra kind of, aura.
I know. In an age where we're talking about Canadians being evil, they make good
Canadians
maple
are
cookies.
not evil. They're great people.
All right, now I saw this. I thought you'd like it since we're not particularly vegan ourselves, but
Oh, no.
my side business I didn't tell you about, they call me Vegan Rob.
Nice.
And I have my own probiotic snacks, and this is Vegan Rob's probiotic cauliflower puffs.
I want to finish this cookie first. This cookie is kind of like an Oreo, but not. It has a white cream in the middle of these two cake-like little slabs.
That's
shaped like a...
That's what a cookie's called, man.
No, I mean, they don't have cream inside like a chocolate chip or anything. But, all right, hit me up with a vegan. I'm going to save this to purge my tongue after this.
We're both on call, so we're
all right.
hungry.
This looks like a Cheez-It, or not a Cheez-It. Yeah, cheese curl, right? But it's white and has kind of a dull appearance like a vegan fast food should.
Right. I think for something that's vegan, that's cauliflower, it tastes pretty good.
Oh, yeah. It's probably the salt. Which tastes good regardless, yeah?
Very true.
It wasn't bad. What that bag cost? Like $10 for 3 ounces?
One thing I didn't talk to you about is that when I was in Montreal, it was a Montreal Jazz Festival. I originally was going to go to the show with Leslie Odom Jr. from Hamilton, and that got canceled.
You mean you and Leslie Odom Jr. were going to go together?
Watch him sing the blues. That got canceled. And then I signed up for the show called Slave, which was songs mined from slavery times, civil rights, and then there was protests because it was cultural appropriation, where not many black people were actually singing it, which I think was a bit tone deaf. And then that got canceled, so they ended up with someone named Kimbra, an interesting show at Club Soda. But the opening...
She related to Kimba, the White Lion?
I don't know. I didn't ask her. But the opening was, it turned out to be EDM, electronic dance music. Do you know much about that?
I know a little.
Okay, there's a woman, Ouri. She came on, but I had no idea. So she comes on with her computer.
Dude, you were at a rave.
Yeah, so weird music going back and forth, and I'm just waiting.
Little ecstasy floating around
Well,
there.
when is she going to start singing? When is she going to sing? And she never started singing. And then a much younger person said, yeah, you really need to be on something to enjoy EDM, which I was not going to be that.
I hope you extricated yourself from that venue.
I did,
pretty quickly.
I've been to an EDM concert, so there you go. All right, so Matt, let's talk about our two sponsors.
Okay, great. So I want to start out with Triage for Pediatrics. They are, as you guys remember, out of Texas. Julie Ortiz is their CEO, and got to say, we are just continuing to be thrilled with their service at our practice. The fact that we can turn off our phones around 11 o'clock, which is the way we have set it up, although it can be set up any way
you want.
Any way that the provider wants, and don't have to worry about things until 7 o'clock in the morning, and that we are just getting outstanding service from Triage for Pediatrics. Very affordable, very appropriate. We are faxed information on our patients' calls every morning, and we honestly could not be happier.
And what's Julie's number?
So Julie's number is 214-450-5053, or she can be emailed at jortiz@triage4, that's the number 4, pediatrics.com.
And our second sponsor, the Campus Quilt Company. Campus Quilts will turn your old T-shirts into a quilt. And right behind me again is mine, and Matt is ordering his up for his family.
You bet. Going to take the T-shirt right off their back. Sorry, I'm still chewing my maple cream here.
And again, with graduations just finished, it's a great gift for your kids going off to college or going off from college onto the world. If you use the promo code Pediatricians when you call in, you get $29 off your order. The T-shirt quilt can be ordered by going on campusquilts.com or calling 502-968-2850 or 1-800-880-8534. That's Campus Quilts. Yeah, great product.
Just really, really cool. I mean, cuddling up in your memories, essentially, which is, one of the reasons we haven't done it yet is because I can't get the T-shirts off my kids' backs to do it.
That's beautiful, Matt. You cuddle up to your memories.
Hey. Ooh.
I'm impressed. All right, we'll be right back.
Okay, we're back to all things scoliosis. Our focus is on adolescent idiopathic scoliosis, which is the most common type. The much, much less common types of scoliosis are the early onset types. These include either infantiles, which is considered to be from 0 to 3 years of age, or juvenile, from 4 to about 9 years of age. These less common types are generally associated with either genetic syndromes or muscle weakness or congenital bone abnormalities, but can occasionally also be idiopathic.
But again, 85% of scoliosis is adolescent idiopathic scoliosis. Although this is not identified necessarily as a genetic diagnosis, it has a really, really strong genetic component. 40% of people with significant adolescent idiopathic scoliosis, or AIS, have a strong family history of scoliosis, and there are definitely multiple areas on the X female chromosome that are associated with scoliosis. For the infantile scoliosis, consider those malformed vertebrae as a source, such as a hemivertebra, where only half of the vertebra is formed, so it's really lopsided. This type of abnormal vertebra can be associated with syndromes, and the most common one is the VACTERL associations. V is for vertebral abnormalities, A is for anal atresia, C is for cardiac abnormalities, TE is for tracheoesophageal fistulas, which is a connection between the upper airway and the upper GI tract. R is for renal, which are kidney problems, and L is for limb abnormalities. And if you find one of these, you always got to look for another. Also, there's a Klippel-Feil syndrome, where there is a fusion of the cervical spine at birth, which causes a short neck, limited mobility, and sometimes spinal narrowing, with one shoulder blade often being higher than the other, which is called a Sprengel deformity. I had one patient with this, and I actually did not pick it up initially, and it was grandma who first noted it very early in infancy. And I think we should do a true grandma episode in the future. I think we both agree the first rule of dealing with grandmas in the office is never diss grandma, unless there's absolutely no choice. You don't want to get her mad at you, and she actually can really help and pick up a lot of things.
Did you get a beat down from somebody's grandmother at some point? Because you seem to be deathly afraid of them.
Maybe.
Yeah. I like grandmoms.
I know.
Yeah.
They're great. Except, again, I said before, occasionally they need to be told that they're not the decision maker.
Yeah, but I make a pointed effort to make them my friends. Yeah. So there are also neuromuscular reasons for scoliosis, where the surrounding musculoskeletal trunk is so weak that the child cannot keep their spine straight and well supported and is more likely to tilt. This situation can include muscular dystrophies and nerve issues like spina bifida or myelomeningocele. This is different from terrible posture, which can cause asymmetry, but not actually structural scoliosis of the spine. And you look like you have pretty good posture there, man. Do you work on that?
Thank you very much, Maddie.
Yes. I was just noticing as we were strolling down the street. Been working on that, Roberto?
Every day.
Nice. Another cause is leg length discrepancy, which creates a pseudoscoliosis. To diagnose this, you just need to have the patient sit on a stool and bend forward, and you can actually see at that point that the scoliosis improves. But we'll get to this later. Have you had any patients with muscular dystrophy, Rob?
Actually, I've had a few, and we'll talk about this in another episode, but I do try to screen every child with low tone, or later on if they cannot run well, with a blood CPK level. And CPK is a muscle enzyme that's elevated in muscular dystrophies and something called dermatomyositis and other muscle inflammatory conditions. And in the past 6 months, I had a boy who had that classic Gowers sign, where when they try to stand up as a toddler, they literally climb up on their own body with their hands. It's one of those moments in pediatrics that you get kind of excited because you're thinking you're making a really uncommon diagnosis. At the same time, you're devastated because if you're right, the condition is serious and sometimes not curable. Yeah. Although there have been some exciting breakthroughs with muscular dystrophies.
Yeah, I know what you're talking about. That's bittersweet.
Right.
When you have that experience.
Right. Hey, Matt, did you watch those muscular dystrophy telethons with Jerry Lewis every year growing up? Ed McMahon?
Yeah, I caught bits and pieces of them. Yeah, usually the talent was kind of second rate. But to watch Jerry kind of slowly deteriorate over the span of whatever it was, 24 hours, was somewhat amusing.
I don't know. I loved watching it. That was kind of like my annual end of the year,
right.
Which I loved, but it made me depressed because it meant school was starting the next day.
Right.
And I hated school. I mean, I don't know
with a haircut like that, no wonder.
And it always choked me up.
School.
It still chokes me up. You'll Never Walk Alone.
Oh,
and
yeah.
I didn't know where that song came from. And then I saw Carousel a few months ago on Broadway, and it's from Roger and Hammerstein's Carousel. Gotcha. And when they go, walk on.
With hope in your eyes, right? Isn't that the part? Yeah. My mom was big on Broadway shows. So when I was growing up, she would always have one of those Broadway albums playing on our cardboard stereo system. Do you remember those?
Yes.
Like the speakers, like literally cardboard.
Right.
Yeah.
Yep.
Right.
And before we get away from the muscular issues, I wanted to mention spinal muscular atrophy, or SMA, which is a group of conditions where the muscles are very weak from birth. And I did a rotation on the muscle ward at Hammersmith Hospital in London with the SMA guru, Victor Dubowitz. He of the preemie Dubowitz scale. Remember that?
Yeah.
It was fun, but in the UK, it's very hierarchical. So the main docs are called professors, and medical students are not allowed to talk to them, only to the chief registrar. So the first day, I thought of a very good question, and he looked at me and he walked away.
Nice.
Now that happens to me in other
You
ways.
are not worth my
but
time.
I just hated it. So I mean, since then, my style has always been whoever asks me a question, whatever they're in training, you treat them with respect and you answer them.
And you probably always say, I don't know.
Right.
Idiopathic.
Right.
Yes.
Yeah. Nothing intelligent, but
Right.
I think the UK still is very much
Hierarchical like that.
Couldn't stand it.
There are other pretty common syndromes associated with scoliosis, like Charcot-Marie tooth with a huge pes cavus or a high arched foot, and weakness of some of the muscles in the lower lateral leg, and also in the hands. Rob, do you remember Todd McCullough? He used to
basketball.
Yeah,
Right,
he used to
right.
play center for the Sixers.
Right.
Yep. Yeah, there you go, right there.
He did.
He did indeed have Charcot-Marie tooth. Yeah.
Wow.
Also, there's Ehlers-Danlos syndrome, which has a high degree, kind of depending. It's a spectrum, but hyperelasticity and double jointedness. The benign form is very, very common. I'm sure we see issues like this at least several times a week in our offices, right?
Right, the hypermobility kids.
Yeah, kids just say, look what I can do. It's somewhat controversial on how much of a workup that you need to do on the children who have this condition and how severe it is. It really depends on that. Have you ever heard of the Beighton score?
Actually, I have. The Beighton score is a score for hypermobility. It's out of 9 by how far you can push your thumb back towards your wrist, how far you can push your pinky back, if you can hyperextend your elbows, hyperextend your knees, and if you can, from a standing position, bend all the way over and put your flat palms on the floor. So if you're high, 5, 6, 7, 8, 9, you qualify, you may have one of these syndromes. And as you said, Matt, it is controversial about how far you go. There's some recommending echocardiograms on all these kids, and I sometimes will have them see sports medicine. I've just seen a lot of disagreements with neurologists and such. So maybe we'll do an episode on that at some point.
Well, you can turn your head all the way around, right? And look backwards. Come on, you were showing me that the other day.
Yep.
Owl boy. All right. Also on exam, look for clues for what may be the source of non-idiopathic scoliosis, like increased or decreased deep tendon reflexes. Another physical finding clue could be café au lait spots, which are areas of increased pigmentation in the form of spots on the body and freckling at the armpits. These spots are seen in neurofibromatosis. Also, the finding of dimpling, or of dark moles, or of hemangiomas, or flame nevi, or patches of hair over the spine can be a clue of the existence of some type of a spinal cord lesion. And do not forget Marfan syndrome. Have you ever had a patient with Marfan syndrome?
I've had a couple.
Yeah, as have I. Yeah, one unfortunately who passed away, but
Of heart problems?
yeah.
Wow.
Yeah. So in Marfan syndrome, again, it can affect people at different degrees, but where patients generally have a wide wingspan, so when they stretch their arms out on a horizontal plane, it tends to be wider than they are actually tall. That's one of the ways that we screen for it.
Although that's one of the things they look for in NBA basketball players.
Yes,
And every time they
exactly.
talk about the wingspans, I'm like, make sure that guy doesn't
get that
have
guy an
Marfan
echocardiogram, will you?
Right.
And so they have that among other physical findings, and as we mentioned, they have an increased risk for significant heart issues. Do you remember volleyball's Flo Hyman, who died in 1986?
I do from the Olympics.
Yeah,
And she was great.
And then many people, although I don't think it's ever been investigated to the extent of exhuming the body, but what about Abraham Lincoln? Right? He had that body habitus as well, that body type, that body shape. But anyway, the bottom line here is that any kind of curve found in a younger child needs an X-ray and a referral to orthopedics. Remember, a younger child.
Now, adolescent idiopathic scoliosis, which again is defined by a curve of greater than 10 degrees, occurs in about 3% of all humans. However, only 10% of those 3% with AIS need to have any treatment. So you would only do something in about 0.3% of people, or 3 out of 1,000 people. And while we think of this type of scoliosis as occurring mostly in girls, when you use that definition of greater than 10 degrees, the numbers of males and females is pretty much equal. The real difference is when you just look at curves that are greater than 10 degrees. As they get more severe, it's almost always girls. So for curves greater than 20 degrees, the ratio is 5 to 1 female to male. If you look at those with curves over 30 degrees, the ratio is 10 to 1 female to male. And for curves over 40 degrees, it's almost exclusively in girls.
So how and where is this scoliosis diagnosed? It's usually discovered in one of three ways. One, either the parent or the teenager notices it, or again, somebody's grandmom.
Yep.
Or number two, it's noticed on a school-based scoliosis exam. Or number three, it's discovered at a physical exam by your friendly neighborhood pediatric caregiver. So to diagnose scoliosis, and especially not to miss subtle scoliosis, one needs to see the entire back, including the shoulders and the iliac crests of the hips, which are the tops of the hips. Sports bras and shirts can really make this more difficult.
And I've made the diagnosis a bit later than I would have liked to on older girls over the years. And I kick myself about potentially missing these girls when they're younger, and I've become a real stickler for having preteens and early teens wear paper gowns in my office so I can see their entire back. And they really, really hate this. Which is also kind of a mild...
Is it that they hate, or is it you?
Yeah, I don't know. No, they don't like these gowns. And I think it's kind of a mild benefit. They're in there in their paper gowns, and I ask the moms if they want to take a picture of their child and post it to Snapchat. They don't think that's funny. I tell the younger kids they can wear it to school. They never find that funny. So what do you do? Are you using paper gowns, or how do you make sure that you're seeing the whole back?
No, we really encourage the kids to the greatest extent that we can to put the gowns on that we give them. And we actually have our own gowns. We have found it more economical to have cloth gowns, and then we do our own.
Wait, you have cloth gowns. So who's cleaning the cloth gowns?
We do our own laundry, man.
You do your laundry?
Yeah, well, my staff is kind enough to do that. So
your nurses?
My nurses, yeah.
Okay, how did you get your nurses to do the laundry?
Because my nurses are stellar people.
They are stellar. I met them. They're stellar, but still, I'd be a little bit cautious.
Yeah. In fact, we're considering like this pediatric laundromat thing going on. Bring your kid and your laundry.
Nice.
Yeah. Nice. Maybe then we can talk the patients into doing our gowns for us, or vice versa. Because
right.
I think my nurses have really proven to be stellar, but I don't need them doing other people's
Maybe
stuff.
You can take this idea in the road and open up a string of
laundromats. It's a franchise,
right?
Yeah, I'll think about that. Pediatromat or something like that.
With some gelato on the side.
Nice.
And fresh pasta.
You betcha. All right. So first, the examiner needs to simply observe the child standing straight to see if the shoulders and the scapula are at equal heights, comparing one side to the other. Also, we need to check to see if the top of the hips and the waistline are equal from one side to the other, and look to see if there's any obvious curving. Typical mild idiopathic scoliosis is at the mid-back or the thoracic spine, and it curves to the right. If it's ever curving to the left, one should always refer and consult an orthopedist, because that is unusual and oftentimes hints of something more serious going on. As the patient's standing straight, if the examiner imagines a plumb line from the posterior process of the lowest cervical vertebra, which is C7, which protrudes out the most from the base of the neck, that imaginary plumb line should pass right through the gluteal cleft or the butt crease. This does not always need to be exact, but it should be pretty darn straight. In addition, the examiner should try to view the patient from the side, as well as from the back, to see if there's an increased degree of kyphosis, which is the normal rounding of the thoracic spine in the upper back, or an increased degree of lordosis, which is the normal curving of the lower lumbar spine. And, of course, there's the classic test for scoliosis, where the examiner has the standing patient bend forward at the waist. This is called the Adams Forward Bend Test.
And contrary to popular belief, this bend test does not really tell you if there's a curve, so much as it tells you that there's a rotation, which accompanies most scoliosis curves, and which will cause a rib prominence on one side when it's in the thoracic region. The degree of tilting, which is created by the rotation, can be measured with a device called a scoliometer. This is not the same as the Cobb angle previously mentioned in reference to x-rays. So, Matt, do you use a scoliometer in the office?
Not often, but we do occasionally.
Until recently, I never did. And I downloaded the free app on my phone, and I started using it. It's kind of like a carpenter's level, and you move it up and down the back and see what kind of angle comes up by rotation. 7 degrees of tilt by scoliometer is supposed to correlate to a Cobb angle of about 20 degrees. I think that's a bit exaggerated in my brief experience so far. But again, not all kids with scoliosis have any rotation. So the scoliometer reading may be normal with true scoliosis, and alternatively, not everyone with a trunk rotation has scoliosis. So the scoliometer reading may be abnormal with no scoliosis being present at all. In overweight kids, significant scoliosis can be hidden somewhat using the scoliometer. So the screening cutoff when you're overweight is 5 degrees or more, whereas it's 7 degrees in kids who are not overweight.
And that's all fine, but I think it's important not to rely on a scoliometer to decide if you're going to refer or to get x-rays or not, even though the official guidelines do rely on it.
You know, after using it for several months now, I completely agree.
Yeah.
It's not going to be
It's
part
a
of my
little
routine.
subjective, yeah. Sometimes back spasms and pain can cause an apparent scoliosis. These causes are part of the functional or the non-structural scoliosis group. In these cases, the spine is structurally normal with no rotation or asymmetry. There are 3 types of non-structural scoliosis. Sciatic scoliosis is caused by pain and or by muscle spasm. Allostatic scoliosis presents with a twisting lower lumbar curve caused by spondylolisthesis or a slippage forward of vertebra due to spondylolysis, which is a condition with stress fractures of the sides of the vertebral arch. And yes, we will cover all that in the near future in our back pain episode. The second type is postural scoliosis, which we see commonly and which will actually resolve when the child lays down. This is the most common type of non-structural scoliosis. The third type is caused by leg length discrepancy. Here, the prominence of the curve, or the concave side of the curve, is on the side of the back that correlates with a longer leg. This type of functional scoliosis will go away if you have the patient sit on a stool and bend forward. So one can try to do that whenever one suspects a new scoliosis diagnosis to see if that maneuver changes things. Certainly you can measure each leg as well, from the anterior superior crest at the front of the hip bone to the medial malleolus, or the ankle bone on the inner aspect of the ankle. Any difference between the leg lengths of over an inch, or 2.5 centimeters, is certainly significant. Often the fix for this is a heel lift for any shoe to be worn on the foot of the shorter leg. So again, the Adams forward bend test isn't perfect, and its interpretation largely depends on the skill of the examiner. This brings us to the topic of mass screening at school.
So school screenings for thoracic scoliosis of 10 degrees or more have a sensitivity of about 80% and specificity about 85%. If you're looking for the more severe scoliosis above 20 degrees, the sensitivity is better at 96%, but still a specificity of only about 75% or so. And Matt, do you know who was one of the first pioneers of scoliosis diagnosis and treatment and first recommended mass screening in schools for scoliosis?
Can't say that I do.
It was G. Dean McEwen of Wilmington, Delaware, at the old Dupont Institute in the 1960s.
Go Delaware.
Now Dupont Hospital for Children. So back then, as Matt trained there and I worked there, it was known as the Institute and everything was free. Parents used to tell their kids at the time if they weren't good, their parents would leave them behind the Institute walls, which were and still are topped off with shards of glass, supposedly so that the children could never escape, or maybe some of the old Dupont relatives could never escape.
Yikes!
You heard that?
Yeah. Well, and isn't that design based on? I think the Dupont's trying to recreate like provincial France or something.
Did
Wasn't
they have
that the way?
shards of glass?
Yeah. Shards of glass at the top of
Okay.
walls to prevent people from invading like their territory, their space, their homes.
Probably
Yeah.
just the peasants.
Yeah.
Trying to
Well,
invade their
duh.
homes.
Yeah. Of course.
But that story about the parents warning their children, I got that from our friend Dr. Kelly in Hershey, Pennsylvania.
Excellent.
So anyway, in 2004, the United States Preventative Service Task Force, or the USPSTF, gave mass school scoliosis screenings a low D grade, pretty much recommended against it. They cited the lack of direct evidence for its accuracy and the potential harm of unnecessary x-rays and unproven treatments.
But in January of 2018, an edition of JAMA, the Journal of the American Medical Association, updated the USPSTF, reevaluated that screen, and changed the grade from a D to an I. And the I means insufficient evidence to confirm or deny the effectiveness of the screening. This is because new studies had linked some increased benefits of brace treatment and scoliosis-specific exercises. So the USPSTF went from being against school screening to be essentially neutral on the topic. The crucial study was in 2013. It was a landmark study done by Weinstein and colleagues and published in the New England Journal of Medicine. It was the first well-done study to show that bracing really can and does help prevent surgery. And we'll touch on that study a bit later. So now everyone is more in line with the American Academy of Pediatrics, which endorses school-based screening for scoliosis, as do the American Academy of Orthopedic Surgeons and the Pediatric Orthopedic Society of America. It's well known that the average child referred for suspected scoliosis in a school-based exam will have a curve that is milder or even not clinically significant compared with somebody referred from a family member, again, maybe grandma, or someone picked up by their pediatric caregiver.
Bright Futures, which is the Pediatric Primary Care Bible, recommends checking for scoliosis in every child over age 7. But I don't know about you, Matt. I check for scoliosis at every visit, and certainly when they can stand, I have them do the Adams Bend test, even starting at 4 or 5 years of age, especially for girls starting at age 8.
Have you picked up anything with that?
Not that I can remember.
I actually have.
I've
picked up 2 cases of what actually turned out to be idiopathic congenital scoliosis, and those kids were 3.
Right.
Mm-hmm. Yeah, so definitely worth your while.
I'm gonna keep doing it, but that's good to know that you picked it up.
Yeah.
It's also why it's kind of infuriating that insurance companies more and more won't pay for yearly well visits, especially on those girls 8 to 11 to 12 to 13, where it's crucial to pick it up. And I don't mind if they're getting school-based screening as long as it's not part of an effort to erode the pediatric medical home's yearly well visits or shunt the patients off to some school-based wellness centers, which are not pediatric medical homes.
Yeah.
Amen?
This is becoming a bigger topic. Amen.
Yep.
Amen, brother.
All right, Matt. You suspect scoliosis based on your physical exam. What else do you want to know from the family?
I thought you'd never ask. Well, has the patient or the family noticed it progressing? If somehow they had noticed it and brought it to your attention and they said it seems to be getting worse, that's a big red flag to have them see orthopedics right away. Another question, is there back pain associated with it? Most idiopathic scoliosis in youth does not have back pain. Pain makes you think of disc problems, or spondylolysis, or spondylolisthesis, or Scheuermann's disease, which can sometimes include a painful kyphosis or rounding of the mid-back seen in teens. I've had a few of these, and the x-ray shows anterior wedging, or a narrowing in front of the vertebra so that the spine tips forward. And this is a frustrating condition for some of the patients that we see, and innocuous in others.
I agree. I had one child with Sherman's, and often it can be mild, but this particular person was an athlete, and he had chronic pain, and it ended his athletic career.
Yeah.
And he's in his mid-20s and still is having pain, and no one can help him that much with it. So I think Sherman, as much as it's thought of as being, mild or not a big issue in cosmetic, sometimes it could be a bad issue.
So also spine infections and spinal cord tumors fall into the painful category. Next question, is it a left thoracic curve, meaning the convex or the curved part is on the left, with a prominence on the left at the upper back? If so, there may very well be a serious underlying cause, and orthopedics needs to get involved ASAP. Another question, do you suspect any neuromuscular conditions due to findings of weakness or spinal cord findings or even brain problems with clues like bowel or bladder problems or headaches or neck pain? Is there difficulty breathing due to mechanics? But truthfully, respiratory compromise only happens in a really, really severe case of scoliosis. And I don't know. Have you ever seen it, Rob?
Nope.
No, I've not either. And again, it bears repeating, look for leg length discrepancies.
Ask if there's a family history. As mentioned, it's a very strong genetic component. And although a family history won't necessarily change the individual management, it's important to know and encourage you to look more closely at all the siblings. Siblings of a child with scoliosis have a 7% chance of scoliosis compared to a baseline of 3% in the general population. And I've had wise orthopedic surgeons tell moms in my practice when their child was diagnosed to make sure they bring the siblings in to see me to look, and one did, and I found pretty significant scoliosis that I had not seen or somehow missed about 6 months before. So once you find it in the family, you got to look really closely at everybody else.
Yeah, I've had a few families where this definitely was the case.
One of the biggest determinants of how you manage a child and how aggressive you manage them is what stage is that child in their pubertal development. The onset of puberty, which is called Tanner Stage 2, and in a girl that means the development of breast buds, it signals rapid growth and therefore possible rapid worsening of scoliosis. The peak height velocity, during which the most significant worsening of scoliosis is seen, occurs about 6 months prior to a girl's first period, which is called menarche. Menarche is usually a couple years after the appearance of breast buds. The average age for this peak growth, and therefore the high-risk window for scoliosis, is about 11 and a half years for girls and about 13 and a half years for boys. So if a child is in early puberty, especially before the first period occurs in girls, you know that any scoliosis that they have is likely to get worse, and they need to be followed closely.
Okay, you think there's scoliosis. Now what? Well, first you need to see how severe it is by obtaining an x-ray and that critical measurement, the Cobb angle. For me, if the scoliosis is obvious, or if I see clues of underlying pathology, I'll just send them directly to orthopedics and let them do the x-rays. If I'm ordering the x-ray myself, we get a standing, full-length, posterior anterior, or PA, x-ray of the spine, and then a lateral x-ray of the spine, from C7, which remember is the bottom of the neck, to the sacrum, or the bottom of the spine. The radiology folks have the patient put their back to the x-ray source, which is the PA orientation, in order to reduce the amount of radiation that gets to the breast tissue and to the thyroid gland, which is in the anterior neck. For the very first time getting this set of x-rays, that lateral x-ray is important to make sure there's no significant lordosis, or inner curvature, or excessive kyphosis, which is outward curvature of the spine. Now, in 2018, the best method for looking for scoliosis is using the EOS system, which is only a third of the radiation dose of the traditional method and allows for 3D imaging. Unfortunately, this system is only available in certain areas. We're lucky to have 2 children's hospitals nearby which have this system.
But be warned, I've found that sometimes the EO system films are incredibly expensive for families, especially if they have high deductibles. And honestly, this seems to happen more at one of our children's hospitals than the other. And I think that our closest one codes these EOS x-rays as a regular x-ray, and radiology does the same, so it's about the same price. But at the other one, it's upcoded because it's a 3D system, and honestly, I think the increased expense all comes from the radiology charges, even though the orthopedic surgeons are reading it themselves. Yeah. And not really paying attention to much of what the radiologists say.
Yeah. So is there a place for MRIs here? In rare situations, an MRI can be helpful, particularly if there are worrisome neurologic findings, or the x-ray findings indicate some other possible spine problems. The standing x-rays can also help determine the skeletal maturity, therefore where the patient is in puberty and the possible future course of the scoliosis, as we had discussed. This can be assessed looking at the top of the iliac crest, or the apophysis, and estimating how much of the cartilage there is turned to bone. This is called the Risser sign. A Risser grade of 0 to 2 means that the child is still skeletally immature. Risser 3 means that the bone is 51 to 75% ossified, and when you hit that level of maturity, there is a little growth remaining, and it's likely that bracing won't help. We'll get to bracing in a minute. Risser 4 means that over 75% of the bone is ossified, and for girls, that means that they are done growing. Risser 5 indicates complete ossification, and for boys, that also means that they're done growing.
But, Matt, hold the presses. There's a newer method that many orthopedic surgeons are starting to use to evaluate skeletal maturity for scoliosis. This uses x-rays of the hand and wrist, just like we do when we get a bone age when we're worried about puberty issues and short stature. This method, called the Sanders classification, has a rating scale from 1 to 8, and it seems more accurate than the Risser scale, especially in determining the time of peak growth velocity, which is crucial for brace and surgery decisions. So we will likely be seeing more Sanders classifications use than Risser in the future, although the Risser has been the gold standard in pediatrics for quite a long time. Now, a really new possible breakthrough is the attempt to use the 3-dimensional EOS imaging to also better predict the degree of skeletal maturity and how much scoliosis may progress. Now, that would be fantastic because you're already getting the x-ray EOS anyway. That's it, folks, for Scoliosis Part 1. In our concluding episode, Scoliosis II and King Richard III, we'll wrap up scoliosis and when you should refer, and all the different treatments which range from doing nothing to bracing to having major surgery. And good night, Mrs. Calabash, wherever you are. Acha-cha.
Walk on with hope in your heart, and you'll never walk alone. You'll never walk alone. Good night. God bless you all. Thank you so much.
Podcast Pediatricians Productions. All rights reserved.